Hi, everybody. Thank you for joining us today. Really excited to kick off this presentation. My name's Cat Simmons. I'm one of our clinical educators and also our clinical content manager with Diagnostic Solutions Lab. Here with me today, I have Dr. Jaclyn Smeaton from Precision Analytical. She's their Chief Medical Officer and brings really valuable insight to the Dutch testing. And then we also have our guest practitioner, Lexi Yoo from UDirect Health in Indiana. She's a nurse practitioner and her practice specializes in functional medicine, anti-aging medicine, and aesthetic medicine. And she uses both the GI map and the Dutch test as foundational tools in her clinical practice. So very excited to learn from her insight. So Lexi, let's start with you. Can you speak to just kind of, how you get started with patient assessment and your sort of thought process in using both the GI map and the Dutch testing and where you tend to start?
Sure, absolutely. So, I love incorporating both tests into practice because it really helps us hone into root cause and how certain processes can impact other healthcare or other health systems in the body. So I typically start with a comprehensive blood panel through just serum testing. I do that based on the intake and the H&P I do with the patient. I do a lot of questions and looking through symptoms, specifically things that are related to hormone fluctuation. So looking at things like headaches, menstrual migraines, acne. And so I always tell patients on my aesthetic side, if there's something going on the skin, there's a good chance that there's something probably going on in the gut as well. And then I kind of dig deeper into the GI symptoms, looking at things like bloating, gas, constipation. So if the patient says that they are constipated, and they tend to struggle with some of those higher estrogen symptoms. A lot of times I'm thinking maybe their body is not eliminating well, maybe they're not detoxing well, maybe they're not methylating well, and that's where jumping into some of these integrative tests can be super helpful. I'll also go back and kind of look at the timeline. So in functional medicine, we kind of look at antecedents, triggers, and modulators. So looking at if they were on antibiotics often as a kid, were they on oral contraceptive pills, because that can completely change the microbiome, looking at things like SSRIs, and then looking more specifically into some of those hormone questions, honing in on things like estrogen dominance. Those symptoms would typically correspond with a history of constipation, breast tenderness, uterine fibroids, dense breast tissue. A lot of times, those are going to be your patients who have to come back and do the second review of their mammogram. Heavy periods. As well as a shortened luteal phase. So the shortened luteal phase is also something that we will see corresponding with those higher estrogen symptoms. And so I'll have conversations with the patients. Is it that your body's producing too much estrogen? Maybe not. Maybe it's absorbing too much of it in relationship to where your poor little progesterone is. And so that's where you'll get symptomatic. So you'll start to see irregularities in their menstrual cycles, either really heavy periods or it's like every 2 weeks they have like a little bleed. And so again, typically corresponding with your shortened luteal phase or low progesterone. And then also looking at things like if they're bleeding that much, looking at iron and ferritin, because that can also play into thyroid production, energy, and all those things. So start with a blood work, and then I put them in piles. So I'm like, okay, this is my hormone pile, this is my gut pile, this is my thyroid pile. And I tell my patients, I'm like, hey, we're putting this on this pile. And so I'll start to look at those things. If they're in perimenopause, we're typically going to start to see symptoms of deficiency in things like progesterone and testosterone. And so those are the two kind of hormones that I'm looking to optimize. If they're postmenopausal, which that could be a whole nother section, but if they're postmenopausal, then we've got all three that we're typically focusing on. What I really like about the Dutch comprehensive panel is that it'll help me look at cortisol, it'll look at organic acids, it'll look at some other things that are kind of key indicators as, where do we start? So I typically do the serum testing depending on blood work and what their symptomatology is. I'll jump into the GI map testing. Our protocol is typically 12 weeks, and we're seeing the patient every 4 weeks, because a lot of times it's like we start an intervention. So it's like the test retest model. Start the intervention, bring them back, have that conversation, especially because supplements, I always say, are the easy part. The nutrition piece of it is absolutely crucial when it comes to those things. And looking at those things like, are their symptoms getting better? Looking at elevated beta glucuronidase on the GI map, because those are the symptoms I'm going to see with those higher estrogen type things. And then not only that, looking at hormone metabolites on the Dutch test will help me determine, are these hormones I'm giving the patient going down the right pathway? So if I'm giving them testosterone, I want to make sure it's not all piling down that 5-alpha reductase pathway, that I'm actually making sure it's being used appropriately. And that will help me guide a lot of the lifestyle and nutraceutical interventions that we do for the patient.
Awesome. Yeah, no, thank you for that. Definitely a comprehensive assessment. I love a lot of the things you said there, kind of the skin being the gut inside out, and just kind of the detoxification through the GI tract. And then of course, if you're doing, hormonal work, you want to make sure that it's going down the right pathways. Otherwise, it's all kind of for naught. So that being said, let's just kind of do a little stage setting, and we're going to go through a case of Lexi's here in just a few minutes. But because we're going to be focused on these two tests and using them in tandem, let's take a look at the GI map. I'm sure a lot of you have heard of it, but really what sets it apart from our perspective is first and foremost the technology. We use quantitative PCR, so we're really able to identify those low-level microbes, low-level targets that other technology platforms just can't see that low into the microbiome space. So there's that. It's a really well organized test. Everything on the test is clinically actionable. We're looking at clinically relevant targets. So it's very nice and concise. You can get through it very quickly. It's not a cumbersome report. All of our practitioners really appreciate that. And then finally, it includes intestinal health markers. And we're going to talk about that today, including beta-glucuronidase and our digestive markers, which are super important and markers of inflammation as well. So we'll go through that. And Jaclyn, do you want to speak on the Dutch? What sets that apart?
I'd love to. So Dutch stands for Dried Urine Test for Comprehensive Hormones. And like Lexi mentioned, it's a really popular test for practitioners who really want that functional assessment at hormones. Now, we're very supportive of serum testing for a number of reasons. It's insurance covered, it's valid, it's the gold standard, and you can get so much information from it. And the urine gives you a little bit of a different point of view, particularly because we add metabolites to it. So when you look at serum testing, you are basically taking a snapshot. It's a look at, one great example was like if you look at someone's meal, what they're eating in that moment, versus if you took someone's nutrition over the course of an entire day or an entire week, you would get a different assessment than just the snapshot. And urine is that kind of time stretched evaluation of hormones. So you can take a look at hormones over a longer period of time, in this case, over a 24-hour period, to really get a good comprehensive look. So it's a really good in-depth look into sex hormones. It does measure estrogen, progesterone, testosterone, DHEA. We can get a good assessment of what those hormone levels are. But like Lexi mentioned, we also measure many downstream metabolites. So you can see exactly what's happening. So the reason why this is so helpful, let's say you have a patient that has low estrogen levels on serum. You might actually find that their estrogen production is adequate, but their metabolism is really fast of estrogen. They're not keeping enough around. Or you might find that their production is low. And that's two different problems that you could really get more information about how to treat. The Dutch test also includes cortisol, either measured through urine or saliva, depending upon which test panel you run. But again, not just that diurnal curve of cortisol. We also can add the cortisol awakening response, which is an independent measure of HPA axis function that we're finding even more in the literature now compared to the diurnal curve of cortisol. And then also cortisol metabolites, which can give you an insight into inflammation, thyroid function, metabolism, and so many other pieces there. The test also adds organic acids, which tell you a little bit about some of the nutrients that are required for good HPA axis and reproductive function. And then I think the other big things are it's an at-home collection. You basically pee on a piece of paper. It's as easy as a pregnancy test or, if you're a female and you've ever done that. And the other thing is the accuracy and precision of the results. I mean, we are one of the only labs in the functional medicine space that's really committed to aggressive peer-reviewed literature. We've published in steroids many times. We actually recently had a publication accepted. It'll probably be live by the time this is live for in menopause, comparing estrogen response from FDA-approved gels, FDA-approved patches, and estradiol creams that are compounded. So we're really committed to being compared to serum, making sure results are accurate. And really, we don't see that in like saliva testing of reproductive hormones, for example. So really reliable and precise.
Awesome. Yeah, I mean, that's what it's all about. So I'm excited to see this put to use. So Lexi, we've got a case that you've presented, a patient you've been working with for the past couple of years. Do you want to just kind of walk through this case presentation and
Yeah, absolutely. So I picked kind of a Rubik's Cube of a case is what I call them, is when they've got multiple different kind of interesting things happening all at the same time. And you're trying to figure out what is triggering what and what is preventing what from happening. So this is a 43-year-old perimenopausal patient. And she has a past medical history of Hashimoto's thyroiditis, which is unfortunately one of the most common autoimmune conditions we see in our population. She also has a history of POTS, which is postural orthostatic tachycardia syndrome. She also has a history of Epstein-Barr virus. And I think another little piece of this that kind of I went back and looked at is she was also working with another provider who was potentially working her up for mast cell activation and mold. And that's not really what I focus on in practice, but from what I've been learning is that a lot of times you find those often in tandem with each other. So she's got the full gamut of that. She's also got some insulin resistance, strong history of anxiety, and what's so sad is she says I was never like this until I got POTS, and then now she's just an anxious person. Lots of sleep disturbances. And so when I think anxiety and sleep disturbances, I often think, what is her progesterone doing, right? History of constipation, typically has one bowel movement per week, which that is nowhere near enough for many people. Gets bloated after eating, and which would make sense because nothing's pushing through. She started to notice she got some itchy bumps on her skin with gluten consumption. So she was trying to remove it. I mean, she's a mom of 3 kids. And so I always say it's like the drive-by Cheez-It. And so you're walking by your kid and they're eating Cheez-It, so you get the drive-by Cheez-It. And so it's hard. It's hard, history of migraines and headaches. And that's been more recently, kind of, she said, yeah, as she's approached more into her 40s. Fibrocystic breasts. She's had a 25-pound weight gain over the past 3 years. Part of that, though, she was a very active person. And then kind of with the diagnosis of POTS, she's like, I can't do anything but just like breathe. She has some vaginal dryness, decreased sex drive, and hair loss for her. So that's kind of how she presented. We did blood work. We got some serum levels, but with that history of constipation, we've got to start in the gut. We have to, and just kind of see what's going on here. So kind of as I pull up her commensal balance sheet here. So when I look at the commensal balance sheet, or the commensal and keystone bacteria, I typically explain this to my patients. These are the good guys in the gut. These are who are supposed to be there and help your body and metabolic function, and everybody kind of just help each other out kind of thing. So when I look in particular, she's definitely got some insufficiency dysbiosis. So what I always say with this one is, you don't have enough of the good guys, right? We got to feed the soldiers or feed the good guys in the gut. So couple things that will typically kind of point things out here is that she's got low butyrate production. So looking at the lower bacterial phyla, that's your Bacteroidetes and Firmicutes, and those are being low. Some of the other things that I will typically see with that is that acromantia, hers was actually okay, but sometimes patients, when they're low in that, you can start to see some more metabolic dysfunction on that one. And then she's completely absent of that fecal bacterium. Some of the other things that I'll typically see corresponding with this type of pattern are constipation and bloating as well. And then if we look at the next page here, we're starting to see that she's got steatocrit and elastase. And so I typically see this with patients who struggle with weak digestion. And so if we think about those levels on a continuum, where I want that to be is in the green, right? So one other kind of clinical pearl that I've learned is when that steatocrit is fairly high, I go back and I'll ask them, hey, do you have a gallbladder still? Because if they don't, that would be definitely an indication that, they may benefit from some ox bile or something like that. But that definitely with the lower pancreatic elastase. So, it's, in the normal range, but we always say, what is normal versus optimal? The optimal range of where I want that pancreatic elastase to be is about 500 or greater with that one. Kat, do you have anything to add with any of that?
No, I mean, you're on a roll. You're pointing out the things, but definitely, the elastase over 500, a lot of people are confused by that because by conventional standards, 200 is that cut point, but we certainly educate at DSL. We like that over 500 for optimal pancreatic outcomes, and that aligns with literature as well. And just to speak again, to the insufficiency picture, that less than detectable Faecalibacterium prapnitzi, that's a really important sign. That organism, it's a keystone butyrate producer. Butyrate is largely responsible for maintaining the barrier integrity, kind of this whole concept of oral tolerance with foods and food sensitivities. And when we see that as low as it is here, non-detectable, that tells us that there's an inflammatory skew in the gut and in the microbiome. That organism, I kind of personify these bugs a lot, and I call it high maintenance, right? Like, it's like, if inflammation's going to the party, I'm not showing up type of thing, because it will not thrive if there's pro-inflammatory conditions. And so, increasing that guy is really important. And one of the important ways to do that is sort of shifting that inflammatory skew.
Yeah. So a big thing with that one too is I always say, we want to feed the good guy. So, butyrate can be really helpful, increasing your prebiotics, increasing your fiber, those kinds of things. So yeah, absolutely. And then looking at one of my favorite things to look at, which is like kind of if I'm driving a car and I see this beta glucuronidase, I'm like, all right, turn the corner at Dutch, because that's where we're going next. So this beta glucuronidase. And so the way I describe it to patients, so we do a fair amount of hormone replacement in our practice. So beta glucuronidase is kind of what I describe it to my patients. It's a detoxification marker of estrogen metabolites, right? So in my world with hormones, that's kind of how I look at it. And so we've got, phase 1 to phase 2. And then we've got phase 2 to phase 3, which is that elimination. I know Jaclyn will kind of get in a little bit more of it, but when I see that tells me, okay, constipation is causing a reabsorption of these estrogen metabolites, and that could be what's driving a lot of this system. So a lot of times with this, I will really try to focus on helping them eliminate. Also on a serum level, looking at things like their LFTs, because their LFTs can give you some insight, like she is not detoxing anything, right? So looking at things like milk thistle, castor oil packs, lemon water. For the beta glucuronidase, looking at things like calcium D-glucrate. I know I feel like I see all the time in functional medicine, oh, everyone gets DIM. And it's like, no, don't do that. Some people can't do DIM. Sometimes you got to unclog the drain before you put more water in it. And so this is a big key indicator that I personally look at with my patients when I am like, okay, now we got to look at the Dutch test. Although symptomatology on this patient, she needs a Dutch test, regardless what her beta glucuronidase was telling me. So that's typically kind of what I would see there.
Awesome. Yeah. So we do see that elevated beta gluc here. And I know, at Dutch, Dr. Carrie Jones has done so much education on this. I think we're all probably familiar with that box with the bow analogy that she really put on the mark. So it's basically like, breaking that bond and sort of freeing these toxins that the liver has worked so hard to package up. And it's sort of like reversing what we're doing. A couple other things about beta gluc, on the GI map, it's an enzyme, and we are measuring the enzyme activity, and that enzyme activity actually increases at a higher pH. So if there is digestive insufficiencies, hypochlorhydria, which we see that all the time, especially in someone with autoimmune thyroid disease, that's another reason why we might see high beta gluc. So connecting the dots with the digestive weakness and elevated beta gluc. But yeah, so we've got our GI map results. We've got an insufficiency picture, inflammatory skew, digestive weakness, and this high beta gluc. So that's a lot to go off with. So Lexi, what's your initial plan?
Yeah. So with this patient, let's see here. So I'd like to start her on some calcium D-glucarate estrogen, and this will help inhibit the beta glucuronidase activity. I want to support her estrogen detoxification pathways, and that would include things like, managing stress, sauna, red light therapy, supporting liver detox, increasing her water intake, increasing her fiber, butyrate. Probably getting her on a good probiotic as well to kind of start really kind of feeding those guys back in. And I know this is not about peptides, but in our practice, we use quite a bit of peptides. And so utilizing some of our BPC 157 to really kind of help bring more of that back into the gut, because that's actually already made in the gut. Her acromantia was actually okay, so I don't know if I really would need to replace anything like that. But supporting all those things as well, and then really trying to continue to work on supporting some of her hormonal symptoms while I'm waiting to then do a Dutch test. From a dietary perspective, I know we kind of chatted a little bit about this. Um, because she was working with that other practitioner, she I did do some elimination with her because she had said that certain gluten things kind of make her skin a little itchy. And, we have this concept in autoimmunity of molecular mimicry, right? And so it's like autoimmune attack on the poor little thyroid. And it's like, no, it's just dairy. Don't worry. Or no, it's just gluten. So we did a quick 21-day elimination. And then after 21 days, we pick one food and then we slowly incorporate it back in. So that's kind of where we were at. She did get some improvement with symptoms, but ultimately we needed to get into a Dutch test for that.
Great. Yeah. Yeah. I'd love to have you back sometime and do like a whole webinar dedicated to peptides, because that's such a huge space. And
yeah, it's amazing.
I mean, I'm constantly mind blown by it, but that's a topic for another day. But I'd love to hear a little more. I think our listeners would really appreciate a little bit of direction in terms of using calcium D-glucarate for elevated beta gluc, and sort of timing of that too. Like, okay, so you're going to run a Dutch. Are you going to initiate that before we collect for the Dutch, or talk to me about your thought process there, and talk to me a little bit about the mechanism of action.
Right.
I consult on this test all the time, and I find practitioners, that's a step that they don't even know is a possibility.
Right. So, I try to, because these tests and the follow-up to include good nutraceuticals and peptides, they come at a cost, right? So I do try to be very mindful of that for the patient. So I will typically take them through a 12-week protocol, have them come off the supplements, and then jump into the Dutch test. So I can say, so the way I think about it is like I'm kind of helping different detours and highways down a highway. And so then with the Dutch test is I could say, okay, I put the car in the tunnel. Now the Dutch test is telling me what tunnel did it come out of on the other end. So I will typically start with like a digestive support, the 21-day elimination diet. I usually do my beta glucuronidase at after dinner, and I like to do it before bedtime. And I guess maybe the way that I was trained is the liver is doing a lot of work while you're sleeping, kind of thing. And so and that might be, there might be a better way to do it. That's just kind of the way that I do it. And so I typically do that with a little castor oil pack at bedtime. And then I kind of like, all right, liver's kind of getting its work and the detox pathways are getting its work on. The digestive support, I typically recommend about one capsule before their biggest meals. So that's kind of what that looks like. I usually like to, if I'm ever doing any kind of antimicrobial herb, I will try to separate that from my probiotic by about 4 hours, because I want the good beneficial bacteria from that probiotic to kind of be by itself. So it's usually BPC 157 and my probiotic are at lunchtime, antimicrobial digestive support at breakfast and dinner. And then if in some of the nutraceuticals I use, some of them are weight-based dosing. So if they're greater than 150 pounds, I might have them do one more at bedtime. If they're less than 150 pounds, I might have them do my antimicrobial blend at just breakfast and dinner kind of thing.
I can add a bit about the calcium D-glucarate as well. I know that's an area where there's a lot of questions, and the way that it works actually is pretty straightforward. One of the metabolites of calcium D-glucarate, called D-glucaro-1,4-lactone, directly inhibits beta gluc. So it does work like if estrogen is packed up in the box, tied up with the bow, to use Dr. Jones's analogy, it actually prevents that enzyme scissors from clipping the bow and letting the estrogen back out. And the other thing that's kind of neat about that is that calcium D-glucarate it helps with beta glucuronidase reduction, but beta glucuronidase, it does not only detoxify or release estrogen, it also can open the box on other toxins that are excreted through the gut. So beta gluc is not just a measure, it's not only important when we're looking at hormones, it is also important when we're looking at overall liver function and the ability to excrete toxins, period. So the calcium D-gluc can be really helpful. Now, when we look at dosage ranges, most of the studies, like all things like this, are done on animals, and they use up to 1,000 milligrams per kilogram when they're doing animal studies. They've always been shown to be safe. The max that's been tested in humans is about 2,000 milligrams per kilogram. Again, no concerns about safety, but that would equate to like 10 grams a day. And a capsule is about 500 milligrams. So it's unlikely you're going to be giving patients that much unless you're seriously trying to reduce estrogen, like in instances of cancer, which it is used. There's studies out there for cancer patients where you have an estrogen receptor positive cancer, you're trying to really reduce it. They're on very high doses. But when we look at patients with hormonal imbalance, typically the dose that we're looking for is about 1,500 to 3,000 milligrams per day. So that would be like 3 to 6 caps of a 500 milligram calcium D-glucarate. So I love your dosing, Alexis, of doing it before bed, thinking about like that liver, so much healing and detoxification happens at night. But if you have your patient on that much, you also could break those doses apart to like 2 caps 3 times a day or 3 caps twice a day, however you need to, because it is a lot of capsules to get a really strong therapeutic effect, depending upon how high beta gluc is or how high estradiol is that you're trying to bring down.
Yeah.
Perfect. Yeah.
Yeah,
Sounds good.
looking at that level, because we do see it variable, we do see it slightly over range, and sometimes we see it as high as like 6,000. So it really does make a difference. And one pearl I'll add to that before we move on is we should have mentioned initially, beta glucuronidase is produced by gut bacteria. That's why it's on the GI map. It is considered a general dysbiosis marker. However, in this case that we're reviewing, there's more of this insufficiency picture. So it's kind of unlikely. I mean, you can see high beta gluc in insufficiency due to, again, that inflammatory skew, but it's unlikely that we have, an overgrowth of bacteria driving that level up in this case scenario, but that certainly can happen.
Right.
So, all right. Well, yeah. So beta gluc, that's a huge topic. And definitely when you're linking these two tests, it's a huge sort of bridge between the highways, like you're saying. So let's, so fast forward a little bit and you're going to run a Dutch test, and that timeline, you said you're going to do that 12-week protocol before.
Yeah.
Right?
Right. So my initial plan will be a 21 day elimination diet. And again, that totally might be overkill, but I know she's working with that other practitioner who's concerned for mast cell activation, which it's interesting. There are some correlations with that estrogen dominant clinical picture and high histamine, right? And it could be cyclical. And so that's not really, I'm more of the hormones, but I'm like, hey, like let's try to use what we know, right? So 21 day elimination, and then we'll do a slow reintroduction phase, provide her with the digestive support. I did put her on some magnesium at bedtime to maybe hopefully help with some of her anxiety, but also bowel support as well. We put her on some probiotics and immune support, L-glutamine to really kind of help the terrain of the lining of the gut, something with DGL in there and marshmallow, because that is extremely helpful for the gut permeability that she's got. Like I said, incorporate things like calcium D-glucarate, and then supporting her with progesterone, and then kind of after that 12-week protocol, let's get into some Dutch testing.
I just want to add, I know elimination diets can feel very strict, but I don't know if you've seen the same thing in practice, Lexi and Cat, but so many people, we are so accustomed to the standard American diet. And most of our patients, when they come in, they have never experienced what they could feel like on a whole foods diet. And I really believe very firmly that for patients that come in with these multiple, what did you call it? A Rubik's Cube, Lexi?
Yeah,
That's
they're
such a great
Rubik's
name.
cubes.
They have so much going on that sometimes the most simple things can be truly transformative. It's like, eat whole foods, and here's what a whole food is. Drink this much water, get a sleep and get a 30-minute walk in every day. And so many things will shake out and improve even before we layer on complex testing and complex therapeutics. And so I just want to add that because I know it gets overlooked because it's a hard thing to coach and it's a hard thing to help patients be successful with. But I think it is so critical. And when you think about the mechanisms just of the increased fiber, diversity of phytonutrients, all the benefits they get from that, it could be avoidance of a trigger, but it might also be the influx of so many things that are healing and beneficial for them. So I love that you brought that up.
No, it's so important. I may not have mentioned this in my intro, but I'm a dietitian. I've done this for years. I've been in clinical practice for over a decade in kind of the lab space, and it is transformative. And definitely the building blocks, definitely the fiber. We've got this insufficiency picture that's not going to change without those fiber backbones. And then the gluten piece, and we don't need to go on a huge tangent, but I'll just mention that, we know that gluten is a driver of leaky gut. We know that she's on the autoimmune spectrum. She has two diagnoses, and we know about that molecular mimicry. And, I'm a gluten-free person. It's changed my life for the better in terms of just like functional constipation and bowel motility and gut inflammation. So definitely, as much as we want to say, there's no such thing as bad food, like we've shifted that. We've shifted
Right.
that in our society and our food supply.
Hey, Kat, I think one thing that's also really important to note, because I get this question. So I have a training academy, and this is a question I get all the time from a lot of my residents is, so when anti-Gluten and IGA is high, does that automatically mean we got to cut just gluten out? And here's what I tell them. It could be gluten, but it could also be dairy. It could also be eggs. It could also be, corn. So just because it's gliadin doesn't necessarily mean it's always just gluten, because the patients will say, well, I don't know why I don't eat gluten. Well, again, molecular mimicry, your body can't distinguish. All it knows is there's a stressor and it's triggering inflammation, and we got to react. That's all they know. They don't really care who it is. They just know it's there. So that's kind of, don't get confused by that, because I think early on when practitioners are starting, they're like, I just want a black and white protocol. And and that's what they tell me. They're like, can I get your protocol? I'm like, there's no protocol. It doesn't exist.
Yeah.
I mean, I have kind of like, what do I call it for my NPs? I call it a reference guide. I have a reference guide that I've created with my own nutraceuticals and the dosing and when do I stop it and when do I start it and all those things. But don't get confused about that gliadin IGA, because it means there's something going on as far as an immune response. But don't automatically just think it's gluten. It may be gluten, but it may be something else too.
Yeah. That sort of cross-reactivity, and there's a lot of that's a buzzword, right? That gets thrown around. We talk about a lot on our team because there's so much confusion, but there can be cross-reactivity, and it's actually at the level of the immune system. It's not cross-reactivity on the lab. In fact, there's nothing the lab is pretty well dialed in as far as its specificity for the gliadin antibody. But if the immune system is taking that protein and confusing it as something else, it's going to show up on that lab result. So that's opening up kind of Pandora's box for discussion. But you're right. It is the only kind of food sensitivity marker we have on the GI map, but it might open the door for more than just gluten. And I think that's what you're trying to point out. So thank you for that. All right. Well, so fast forward through the initial kind of phase 1, and then we've got a Dutch test on this patient. So let's go through those results.
Yeah. So the progesterone came back. She was on oral progesterone on that. And so you can kind of see it still, it is within range. And Jaclyn, you can feel free to be like, well, let me tell you more about it. One thing I did experience with her is that her sleep was starting to get better, which is great. So progesterone, I always tell patients, it's like nature's Valium for women. It acts on the GABA receptors of the brain, which can be extremely calming. Not only that, though, is it can also help balance out some of those estrogen symptoms, those higher estrogen symptoms she was experiencing.
Yeah, I mean, I'll add to that. I think what you're looking at on that progesterone piece is the progesterone, which we determine like a serum value based upon the two metabolites that are shown below, the alpha and the beta. But it is great that you can run the Dutch test on a female and see whether they prefer the alpha or beta. So in this patient, she does have a slight preference for alpha pregnadiol, which is great because that alpha metabolite is the one that can cross the brain barrier, interact with the GABA receptor, and be very calming. If you have a patient that pushes more of the beta, it's going to be hard for you to get that additional benefit of progesterone, where some women say it helps them feel relaxed, and other women, they're like, no, it doesn't do anything for me. And that's the difference. It's how they preferentially metabolize it. So it can be really helpful there as an additional kind of learning piece that you can get from the test.
Yeah, absolutely. And so then kind of moving along through the highways is kind of what I say. So we're looking now at the estrogen and the methylation processes. And so, she is perimenopausal. not postmenopausal. And so this is a little bit interesting in that if we look at I always say this looks like a speedometer, where our triangle is where you're at, and your goal is to be between the two stars, right? And so she is looking like she is low, which is weird because she had so many of those estrogen dominant symptoms and that higher beta glucuronidase. Now, keep in mind, this test was done after she already did the 12-week protocol. So a better kind of, retest would have been doing it at the same time that you got that beta glucuronidase. Don't start any interventions, and then we could really see it. So, I don't know if this was low because of the intervention was successful. I mean, that's kind of what I'm looking at here. The other thing I always try to point out to my patients is, and I try to keep things super simple for patients, and I'll tell patients, estradiol is kind of the one that I want it to stay. And unfortunately, it wants to do weird stuff sometimes. And estriol is just the confused one that it doesn't know what it wants to do, right? So we want to then go down that CYP1B1 pathway. We don't want it to go down that. That's our quinone pathway. And so I will often use this test when I have women on HRT, and especially if they've had a history of breast cancer, I'm like, you are for sure getting a Dutch test, because I want to make sure that I'm giving you something and that it doesn't need me to intervene to make it go down the correct pathways, if that makes sense. So for this patient in particular, she looks low. So again, I think maybe it's because we did the interventions on that. Jaclyn, would there be any other, thoughts on like why they would be low here but higher in the serum?
Yeah, they could be. So there's a couple of things. So first of all, I love that you're bringing up like when to test, because we get that question all the time, before or after other interventions, before or after HRT gets initiated. And it really depends on what you're trying to measure. And so it's kind of a, I guess just like when people say, what's your protocol? You're not giving them the answer they're really hoping for, which is direct and clear. But I like that you ran this test after she'd already done the lifestyle interventions, because if you could normalize her hormones based upon lifestyle interventions and she could be consistent with that, that would be great. If she had no other need for, DIM or calcium D-glucarate or sulforaphane or other things that can, affect the estrogen detoxification pathway. Now, the other thing that I'd keep in mind is that perimenopause is really misunderstood even amongst functional medicine practitioners, where it's a lot like puberty. You have cycles where the ovaries are very active, just like they were in the cycling years. And then you have cycles where they're more postmenopausal and they don't respond as well to FSH and LH from the brain. So if you actually look at estradiol production over time during perimenopause, progesterone's kind of a slow, gradual decline, but estradiol is up and down, up and down, up and down. And it can make it really difficult to evaluate females in that time frame, because you might catch a cycle that is unique compared to other cycles where hormone production doesn't match serum, for example. So it'd be better, again, if you can catch the same cycle. For those things might make a lot more sense, but it's not surprising to me that you have a patient here that does have estrogen dominance type symptoms, but then measure low. That's not something that is out of the question. And it doesn't mean the data for either is inaccurate. It might just be that you caught a different cycle and you had lower production on one cycle and higher production on another cycle.
Absolutely. I often give my perimenopausal patients the analogy of like when you're at the bottom of a ketchup bottle and you like flip it up there and you hit it and it goes, and then it's like everything shut out. And then the next like pump is like nothing. And then it's like hit it again. And then it's like,
I love your analogies.
Yeah, that is perimenopausal at its finest. It's like the end of a ketchup bottle.
Especially with the sound effects.
Yeah, it is. They're like, oh, it makes sense, because I'm like, next time you made it, get nothing, right?
That's right.
It is a period of
I mean, I work with fertility, and so I work a lot with women like 35 to 45. That's my patient population. And it is really tricky and it can be very frustrating, but it's like if you're in that age range, you could still get a great cycle and have a great egg and get pregnant, but you might have a couple cycles in between that are that empty ketchup squeeze and really not fulfilling or not successful. So it is, patients need more education about that, and providers do too, to like really provide that reassurance around that. But what I am seeing here, I mean, from a metabolism point of view, it's a little tough to interpret her metabolic preferences because the estrogen levels are lower. When you see them in the normal range or high, the levels of metabolites are also so high that it's really, really great. But here she's like low, 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 right? But you can definitely see that like for estrone and estriol, and then many of her metabolites, she's in that postmenopausal range during this cycle. Normally what we would see, it's like you said, it's kind of between the stars for a cycling female in the luteal phase. And if you're in perimenopause, or actually, let's talk about if you were going to put a patient on hormonal replacement therapy, typically what we recommend is that you aim to be in almost where her estradiol is right now. That would be like a nice range for a female in menopause on therapy, which would be above the postmenopausal range, but just below that luteal range for a cycling female. And a lot of times that's where we see you can get some of the, bone protection, hot flash reduction, those symptoms that you'd be looking for in those results.
Yeah, absolutely. Of note here, I thought it was kind of interesting because she's kind of an amped up person, is looking at her methylation activity. She actually wasn't too bad, which is interesting. But I did have her on a B complex that has methylated Bs and methylfolate in there. So again,
I think
in a perfect world, it would have been like, well, what did that look like when you started?
Yeah, you probably made major improvements through dietary change on that, that methyl dial. But again, I think you like bringing it back to what you mentioned first. Whenever you're working on estrogen metabolism, you want to start at the finish line and work your way back. So you definitely want to start with gut and elimination so that you're not making more, for example, reactive quinones that you can't methylate and can't get through the liver and can't get out the gut. You want to start at the end, making sure elimination's happening, and then move on to methylation if that's a problem, and then move on to phase 1 if that's a problem, and really work your way back there.
Yeah, absolutely. So I believe I kept her on those methylated B vitamins. The next slide is starting to look at her cortisol curve. So we're looking at the diurnal pattern. So when patients ask me, hey, can I check my cortisol? And they want it on blood. And I'm like, no. And they're like, why? And I'm like, because that literally gives me no information. It's like a snapshot. It's like what happened right then. I need to see what happened right when you woke up, an hour after it happened, about midday, and then right before you go to bed. And they're like, geez. I'm like, but that's how I assess over time, right? So diurnal pattern is like the A1C of cortisol because it gives me an idea over time and how your body is responding throughout the day. So with this patient here, she's definitely she's got some weird patterns for sure on that. And so for me, it was kind of hard to see like, is this your norm or like, I'm not sure. Did you have some stressful event kind of in the afternoon? Because that's what it looks like to me. Typical is they kind of rise about a standard deviation or two above, and then it starts to fall. But that afternoon one, I'm not sure what happened there. So I don't know. I kind of look at it as it like maybe it's an outlier.
Well, didn't we notice on her intake form for this that something weird, like it was collected mid-morning or something? Isn't that?
Yeah, the times for her collection were a little later than normal,
Okay.
but her wake up time was also later. So she was someone that I think she woke up at 11 and took her first sample at 11 a.m. But that is what we would recommend if that's her normal everyday schedule. So I agree, Lexi. I think with that cortisol pattern, sometimes there's like, oh, yeah, I had a fight with my husband at lunchtime. Or when you ask your patient about it, they are like, oh, yeah, that day I had to go give a presentation at work or something that, really just drove their cortisol up. So that would be one thing I would check on. The other thing you can look at is hydrocortisone cream application. So if you ever see a weird outlier like that, ask your patient, did you use an anti-itch cream? Did you put something on a bug bite? Maybe even on your kids? Because if you use your hands to apply it to them, you're going to get it on you too. And that can cause a rise in cortisol on test day. So a couple of things to just be mindful of when you're testing. But normally like this, it either could be her normal pattern. And the other thing I would look at is she getting anxiety mostly in the afternoon? Because if she's symptomatic during that time, this might be part of her normal rhythm and really need that support. But if not, let's say she was like fatigued all day and didn't experience anxiety, then I'd be thinking, okay, what else might have caused that spike there?
Yeah, absolutely. So then kind of moving along, looking at Indicin. So Indicin, again, it almost would have been better like if we'd have done it right when the GI map started, because if there was some sort of insufficient, if there with the dysbiosis. So if I'm starting with a Dutch test, which again I normally start with a GI map, but if I have a patient, they come in like I came here because I want to get a Dutch test done, and then that Indicin is higher, I would say okay, and now you just got yourself a gut test too. So that's typically how I use Indicin as a marker of overgrowth and inflammation in the gut. Something is going on there. It's kind of like waving the white flag, like, hey, I need help in here. So that's kind of what I use Indicin for. in particular.
Yeah, absolutely. And in her case, we wouldn't expect Indicin to be high because she's an insufficiency dysbiosis. So I
Right.
will point that out that I wouldn't use only that to determine whether or not you run a GI test because you have like this patient's extremely symptomatic with her GI, but you're not seeing Indicin rise because she's symptomatic due to a lack of beneficial flora, not due to an overgrowth of
Right.
pathogenic flora. So it is a little bit different. You have to keep that in mind. It's overgrowth of bad bugs that will cause Indicin to increase.
Yeah.
Yeah. So looking at that we'd expect Indicin to be elevated more when we have that like page 3 overgrowth and some of those organisms that tend to preferentially ferment protein, produce things like indols and amines and more of that sort of inflammatory skew. So that does add up. But yeah, Indicin's a marker I don't have a ton of familiarity with because it's newer on the touch, right? Just like the past couple
Yeah,
of years.
we added about a year ago, and it's really interesting. We have seen in our own data because as we were validating, is this legit? We haven't published this yet, but we're like kind of doing the data crunching to get it ready for publication. We actually did find across, I think we looked at about 20,000 samples, that when Indicin was elevated, estrogen tended to be higher. So there was a correlation between estradiol and Indicin levels on the test, which was really interesting to see and really kind of innovative, novel data that we really can't wait to get out in the literature.
That's awesome. That's super
Yeah.
exciting.
So as far as follow-up plan for this patient, as over the course of the time I've been working with her, I've slowly kind of etched up on that progesterone to continue to help her. Offered some Vitex or Chaseberry to continue that support as well. I think some practitioners might do one or the other. Studies actually show that Chaseberry can be very beneficial for dense breast tissue as well. So I thought that was also something that could be very helpful. With the DIM and the CDG Esterdim and the I3C, I actually have her off of it right now. But she did find that it does keep her bowel movements regular. So she'll kind of almost use it as like a PRN dose. Like if she feels like she's not pooped in a while, she's like, I'm going to take me 2 CDG Estrodims before bed. She stays vigilant to her methylated B complex. I try to diversify the microbiome. So I always, again, have an analogy from patients. I'm like, all right, you did that one last time. We got to change it up. We got to do another one the next time. Okay, you done use that one. Let's do this one. And so that way someone's always kind of getting some variety and not stuck on the same probiotic every time. And then she does do a great job of staying gluten-free for the most part and does try to eliminate most dairy, but that one's probably a little bit harder for her in general. As far as the symptoms and outcomes, and so her symptoms of anxiety and sleep have much improved. Bloating is also better. Bowel regularity, like I said, she's now educated enough to notice, like, hey, I'm starting to revert back, and so she finds that the CDG DIM helps with her, but she also stays on her magnesium at night. The methylation support, like I said, she does the magnesium as well as the methylated B vitamins, her progesterone. And then we did do a repeat of her GI map, which on that, let's see if we have that here. So you can see on the commensal balance sheet here that, all the guys are there. All of our friends are here. So everyone is present and accounted for and in the green, which is honestly pretty freaking amazing in my opinion. If we look at her digestive capacity, so her steatocrit is now less than detectable level. So if we recall, she had like a 6, I believe. And then her pancreatic elastase, like I said, she was like mediocre. She was like 250. And I'm like, okay, optimal is 500 or greater. She's cruising at 750. So she's absolutely perfect. And then her beta glucuronidase is completely normal, which yay, right? So it took us a long time and a lot of work, but this is probably that Rubik's cube that I'm like, look, if you do the nutrition, you do the supplement, you do the retesting, and you do all the things, it actually can get better.
Yeah, no, this is remarkable improvement. Do you know if, because the digestion improved so remarkably, is she maintaining her digestive support throughout this whole piece?
That's a great question. So she has come off. So I always tell patients, listen, the goal is we're going to get you on some supplements, and then the goal is to come off of it. unfortunately, a lot of times in functional medicine, we'll get patients from other functional practices and they come in with this bag of supplements. And I'm like, what are we on this for? I don't know. They told me to take it. What are we on? I'm like, okay, I don't know. I'm like, well, why don't we actually see what you really need? So I always tell patients, listen, you're going to come on these supplements and then we're going to come off these supplements. And my favorite is when they're like, oh, I got to take supplements. And then they don't want to come off of it. They're like, I feel amazing. I don't ever want to not feel like this. Or I'm only pooping once a day instead of 7 times a day. Or I'm pooping, every day instead of only once a week. And so, no, for the most part, we try to keep them off of it unless they start to get symptomatic. And again, she's so well educated. We've done so much follow up with her. She starts to know what symptom might be improved by something. So no, she only takes it. I think she takes it if she's having like a bigger meal, like if she's going out to eat with maybe some friends or relatives, and she'll take a digestive support. But for the most part, she doesn't.
That's nice. Yeah, that's a good question. We get that question all the time. So it's nice to see that much improvement. And it's not, we're not like functionally supplementing pancreatic elastase, but,
right. No.
Sometimes being on the digestive enzymes gives your body that assist, right? So the lab can look better. So that's nice to note that she's had that much improvement and she's not having to take enzymes at every meal at this point. So great. Well, great work. This is really fun. It looks like you've really helped this person. She's a complicated case to begin with.
Super complicated.
It's a complicated phase of life.
Yeah.
She's a mom of 3, like you said. And so, the goal of this presentation and this webinar and this meeting of the minds today was really just to help our practitioners help illustrate how we can use these 2 tests in combo to do this type of work. And, I just want to thank both of you for being here and sharing your knowledge and insight. And any closing remarks from either of you?
I personally, so I think that the interpretive guide that you can get online through the PDF for Diagnostic Solutions is extremely helpful. I also utilize the Dutch has a really amazing interpretive guide, and so they also have a line that you can call and get on with a practitioner and kind of go through that. I like to marinate on stuff. And so I literally will print it off and then I have 2 interpretive guides, and then I'm like, okay, this means this and this means this. And then, for my nutraceutical component, I try to see, okay, what supplement do I have that has multiple different things in it that instead of like, now you need this and now you need this, I try to minimize it as much as I can for patients, which I think is helpful. So utilizing their free libraries, utilizing their resources. If you're not following the Dutch podcast, you need to. Maybe one day GI Map will have a podcast to have that, because I do find that it's helpful. Like I have a podcast for my patients, like I find it's helpful. So it's like getting little bits of information at a time, I think is so good to digest. The YouTube channels, the webinars, all those things are so helpful, and free resources for practitioners. Because I always tell my NPs, it's expensive to be smart. So I think the resources that both companies offer is amazing.
Thanks for that plug, Lexi. And yeah, I'll just, also add that comment that these 2 tests, we were so excited to partner with education because they're so complementary. You can't assess hormones and treat hormonal imbalance without looking at the gut. And similarly, the gut is impacted by hormones. And so really this comes full circle. So it's exciting to do this. And Lexi, just to your credit, I'm a naturopathic physician trained. So we see a lot of functional docs that come in, but they still are symptom chasing. And when you get a complex case like yours, it can be easy to give something for the anxiety, give something for the sleep, give something for the bloating. So I just want to honor the way that you've approached this patient's case, which really is looking to that root cause and really trying to chase that down. And really, like, just to echo what Kat said, kudos on amazing results. You're impacting people's lives and helping them do it in a way where they can be re-empowered for their own health. And that's just fantastic.
Yeah. Thank you. I appreciate that.
Yeah. All right. Well, yeah. And please check out our education. DSL, we did just launch a brand new learning academy in the past recent months. And I know, the Dutch podcasts and Dutch has webinars. Check out our YouTube channels. There's, like we said, tons of free education. It is expensive to be smart. So, take advantage of what's at your resources. And, this is just one more cookie in that jar. So thank you guys for being here today. And this has been a lot of fun. Let's go through a few. We had a lot of questions about resources, which I think we covered, in the end of the presentation. So if you haven't checked out our DSL Academy, please do so. We had a lot of questions about increasing butyrate producers through the gut and things like that. Had a good question about progesterone. You know, we talked, Jaclyn, you were talking a little bit about the alpha and beta pathway, and we had an insightful question. Is there anything we can do to push more towards the alpha in terms of dosing of progesterone, or I don't know, what strategies would you employ there?
Yeah, unfortunately not that we know of, that there's not a lot of ways that you can shift metabolism like there is for estrogens. And so with progesterone, I think the biggest benefit of understanding whether someone's an alpha or beta metabolizer is to understand whether improving overall progesterone levels would help to calm a patient or not. So I think that's what we think about. Or if you're trying to understand like a paradoxical reaction to progesterone, where someone takes it and feels more amped up, that might be something that we look at there.
Cool, thank you for that. We had a few questions about in the context of an insufficiency picture, like we saw in this case. I guess there's some confusion about, you know, how we would see elevated beta gluc in an insufficiency picture. And I mean, I guess I can take this, but please, you know, feel free to weigh in also. Like, beta gluc is not just produced by gut bacteria. That is one side of the equation. It's also produced by liver and kidney tissue. And of course, what it does essentially is shut down phase 2 liver detox. So we kind of use, you know, this is where looking at the actual result, looking at the number can help us triage. The cut point for beta gluc on GI map is like essentially about 2,500. When that's usually over 3,000, which would be quite high, oftentimes it is coming from other than the gut. So we think liver, we think kidney tissue, we think, you know, kind of liver processing issues, detoxification issues, maybe mold, mycotoxin, you know, as a possibility. So, you know, that tends to be how we educate here. Do you guys have anything else to say about, you know, a high beta gluc with more of that insufficiency dysbiosis picture?
Some of the things that I would be looking for is like underlying causes. So looking at things like some sort of like mold, Epstein-Barr, Lyme, because what could potentially be happening is that they are insufficient and you're trying to replace things and you're trying to help the absorption piece of it. But if there's some underlying infection, oxidative stress, it's almost like you're kind of going up an uphill battle. You got to fix the underlying thing before you can get to the next thing. And so I would be digging a little deeper and looking at other ways to help methylation, detox, glucuronidation, like all the other highways to make sure everything is detoxing. And then if there is an underlying infection, getting rid of it.
Sorry, thanks. Okay, we actually had a lot of questions. I know we went through the gluten and the anti-gliadin on the GI map and the elimination diet piece and how important a whole foods diet is. Do either of you, we had a lot of questions about food sensitivity testing. Do either of you use that? And I can certainly weigh in on my experience with that too.
Yeah, I mean, I can jump in. So I do use it sometimes. I used to use it a lot more. People are very interested. They love the test because it shows like green, yellow, red. It's easy to follow. And I would actually say that a lot of the time, I would have patients that did seem to have reactions, and we did a modified elimination diet based upon testing. That being said, when I've dug into the science behind it, I mean, if you walk the floor of any kind of conference and you talk with 3 or 4 different labs, they'll all tell you why theirs is the only one that's accurate and no one else's is. And the science can be really tough to tease out. So I think for me, the times where I find it to be most effective are, one, when I'm worried about patient compliance on a regular elimination diet, maybe because the elimination of all the foods on an elimination diet would feel so overwhelming that that test can be a little bit more directive for someone and put a little bit of a stake in the ground of, okay, this might actually be an issue because I can see my immune system reacting here. So I do find that for patients that are struggling with just a prescribed elimination diet, or they're not trusting themselves to identify symptom patterns, it can be really helpful to kind of kickstart that process. Also, like, it does tend to show the foods that you've eaten most frequently, most recently. So you are kind of capturing most of the things in someone's diet when you run that testing. But I've also had instances where it doesn't catch everything. So I don't think they're perfect. I think they can be useful sometimes, but if you ask me to like grade the science behind each of them, I wouldn't be the right person to talk about that, for each individual lab.
Yeah, I like to look also too, because a lot of times when we test patients, we'll find that they are Hashimoto's. It's super common. I feel like everybody has it, right? And the thing with Hashimoto's is that it starts in the gut, right? Well, that's one of them. Genetic predisposition, a trigger, and then gut permeability. When you have Hashimoto's, you're 40% more likely to have another autoimmune condition. And so I think, especially family history of anyone else has got celiac, I will sometimes order a food sensitivity panel because they can get that HLA-DQ8 sensitivity. And I tell them, like, I need you to don't eliminate gluten. Like, I need you to have it because I need this to show up, or like a TTGA, or it's there's like a whole there's a whole panel for that. And so sometimes if family history, the symptomatology, but I completely agree with what Jaclyn said is that I can get so much more accomplished with a GI map, and that, these tests are expensive. And so I'd rather put that money towards a Dutch test next instead of a sensitivity panel, because we're going to get far more accomplished that way.
Yeah. And just to kind of close the door on that, if any of our listeners are not aware, Diagnostic Solutions, we do offer a IgG food explorer test, as well as an IgE allergy explorer. And I think that, using antibody testing, you can highlight if a food is evoking a very strong immune response, if you have outrageously high antibodies to a particular food antigen. So a lot of times, even extraintestinal, that can be really helpful if people have raging skin manifestations, or migraines we haven't figured out a trigger for. So they can be helpful. I will say, if your gut is a mess, they're going to come back, lit up like a Christmas tree. So if we're thinking financially, sometimes it does make sense a lot of times it does make sense to start with the GI map, go from there. If you have digestive insufficiencies, you're not fully breaking down your food. So that's going to oftentimes result in more of an immune response, but they can be helpful, and patients do often come in asking for them. But if you haven't tried our IgG Food Explorer, it's another offering on our menu. And one other thing I wanted to mention, DSL has launched this fecal gluten peptide test as an add-on to the GI map, and you can actually now measure 33-mer gluten peptide in your stool sample, which indicates exposure. So anti-gliadin is an immune response. There's a timeline there. We talked about the cross-reactivity, but if you are really wanting to test for your patient's compliance for being gluten-free, we now have that available. And that's pretty cool, because it's a tool that really isn't really around in kind of like the stool testing space in our industry. So I'm excited about that.
Just one more thing about that, Kat. I think one other thing that I've seen a lot in practice is if you're running food allergy panels on patients and they're coming back reactive to everything, I have to really caution you on how you counsel your patients. So I'm sure all of us can relate to the patient who's afraid of eating food. And I know you mentioned in the webinar, food should be nourishing us, it should be healing us. And so if a food allergy panel is just stacking allergens one by one and your patient's down to eating an extremely limited diet, you need to rethink your approach, because the food's not the problem, the digestion's the problem. Most of us should be able to tolerate most foods. And so just again, I would say, if you're lit up like a Christmas tree, I would make sure you're explicit with your patient that doesn't indicate the foods are a problem for them, but they have a digestive issue that needs to be repaired, and then you can maybe retest.
Yeah, I couldn't agree more. There's a certain, psychology, and I'm sure we've all seen the patients that have come to us eating, 4 foods, and so much of our work is,
that's it,
And so much of our work is when you're trying to diversify the gut microbiome, you're not going to do that eating the same 4 foods. Right. So we could talk about this all day, but you just wanted to kind of weigh in on some of those questions. We did have some questions about the Dutch Plus versus the Dutch Complete, and as it relates to specifically the perimenopause population, what is advised, and then, or what you guys would essentially do. And then also within that, collection times, particularly with the urine, particularly if people are waking up multiple times throughout the night, what you're, going to the bathroom multiple times throughout the night, what would you advise there in terms of collecting and then also the testing options?
Great. So just starting with the Dutch Complete versus the Dutch Plus. The Dutch Complete is kind of our flagship. It's a urine-only test. So it's easier for sample collection because you're only doing urine. And we actually can capture the cortisol curve from the urine samples as well. Now, when we move to the Dutch Plus, you include saliva. The main reason for this is that we're adding the cortisol awakening response, which is 3 samples in the first 1 hour. So it's immediately upon waking and then 30 minutes and 60 minutes post-waking. Now, you can't use urine for a carb because urine, is hours of processing to metabolize and get into the urine. And then the other piece is it's difficult to urinate 3 times in an hour. So you have to capture saliva, which is more of that spot check in the minute. So that's when we would add the Dutch Plus. That's really the biggest advantage. Now, I've switched to using the Dutch Plus all the time in my practice. It can be a little bit challenging for patients to add the salivary samples. It's more collection. So if someone wants something simple, the Dutch Complete is great. But what I've found is that there is a lot of data showing that the car picks up a lot of HPA axis dysfunction. And it's dysfunction that we might be missing if we only are looking at a diurnal pattern or even diurnal pattern plus cortisol metabolites. So I like getting that full complete picture. I think it's a good value when patients are willing to do those extra samples. Now, timing of the samples, we want to do it mid-luteal collection for a female, a cycling female. Otherwise, for males and postmenopausal females, it doesn't matter. And if you're waking up a lot at night, you could call if you're waking up really, really frequently and you're unsure about it, but generally we'd still do the morning sample. If insomnia is an issue, you can add an insomnia sample as well at night if you're wanting to look at, for example, what does cortisol look like? If someone's always waking up at 2 a.m. and you want to say, okay, well, what's going on at that time point? Are we getting a cortisol spike? You can add an extra sample and we'll test that in the middle of the night. But most of the time, you'd still start with your true waking. Now, if you're waking up hourly or something that feels confusing, just call our team because we can kind of help interpret that on a case-by-case basis.
Awesome. Yeah, thank you for that. I think the cortisol curve, Lexi agrees, it just adds so much information, and to map that, like you mentioned, the A1C sort of, although it's, multiple time points, and seeing that map and seeing how that changes throughout the day, it's very valuable. You should have seen mine. It was very insightful.
We'll save that for another webinar where the 3 of us show our own cortisol curves.
Oh yeah. Well, yeah. Okay. So, all right. Well, I think we hit on most of the broad topics. We did have a question, when you were going through that ketchup bottle analogy, which I love. Do you ever just do cycle mapping with your patients, Lexi? Is that a lot of times how you get started versus, especially if you're waiting on the Dutch after the GI map, is that something you use, or can you kind of speak to that?
Yeah, so I'm not that fancy actually. I go by, I need the first day of your period and we kind of track it, and then we count that way, and then I go by symptoms. I make them keep a little journal and their notes on their phone, and I'm like, okay, day 1, they download an app, and then I'm like, okay, tell me what day 14 felt like, tell me what day 18 felt like, tell me the day 21, 25. And yes, that's really probably old school, but just because I'm kind of waiting on the Dutch to come back. And so that's kind of how I'm able to kind of put more pieces of the puzzle. Sometimes, like I was saying in my academy, sometimes my students will send me a Dutch test and no synopsis of what's going on. And so I'm like, you're gonna have to call me because I need to know what they're on, what the symptoms were, why are we doing this, instead of here's the results. I'm like, that means nothing to me. So there's so many pieces of the puzzle. All these tests are amazing, but they're, again, putting one more piece to a big puzzle. So no, I go by symptoms, and I have them track their cycles.
Cool. Yeah, and kind of a follow-up to that is, what if, perimenopause, super complicated phase of life, lots of changes, not all the cycles are the same. So what do you advise? And I think the answer is that your team at Precision Analytical has a consult line for this, but if the cycles are just crazy irregular and you can't get any sort of consistency or predictability, what do you recommend as far as collecting?
Yeah, again, this is a time where you could use a cycle map to try to catch it. And what's nice about that is that if someone's mid-luteal, if they were expecting it to be day 21, but things are kind of wonky and it's actually day 10, whatever that's going on for them, or it's day 35, we can do the sample collection where we analyze the right samples for the testing. So we can do the progesterone levels, for example, relative to estrogen and show kind of what the Dutch complete looks like based upon the samples that were mid-luteal, because we can see the whole cycle. So we can kind of adjust the date of sample collection, or like the day of the cycle that was, to show what it should look like if we could like shift the timing to where it really was versus what the patient thought it might be. So that's one thing that's really helpful. And we do have like in our instructions what to do for long cycles. But if for irregularity where you're like maybe regular a lot of the time, but then the cycle that you go to test, this happens all the time, your period doesn't come and you're like, oh God, what am I going to do? Just call the lab. They'll ship a new kit. There's no cost involved. You can catch the next cycle. So it's a little bit of a pain to have to wait when you're doing a full cycle map or even a Dutch complete. If you miss the date, it's really not a big deal. You kind of pay at the time of processing. So we're happy to ship another kit out so you can collect on the day that'll be most valuable.
Okay. And how about if someone is on like a birth control and they're not having a cycle?
So with birth control, we don't recommend doing the testing because we can't really measure the impact of the synthetic hormones with the Dutch testing. We can only measure like bioidentical, naturally produced hormones. So with OCPs, we generally recommend people would discontinue them and then test, once you've had a cycle off of them. Yeah.
All right. Yeah. Okay, well, I think we're gonna probably wrap up here. I know we've gone over the hour, but we wanted to just give the opportunity for some Q&A. Lexi, we've had a few questions about your mentorship program. Do you want to share how to get in touch with you and how that works and how people can be connected? I know you have an awesome Instagram presence as well. So.
Yeah, so I'm in Indiana. I have a virtual, totally online training platform. It's called ydhacademy.com. So Y as in you, D as in direct, and H as in health. ydhacademy.com. I have 6 different kind of modules that I've created: women's health, men's health, thyroid, gut health, aesthetics, and peptide therapy. So there's 6 modules. And where I feel like, and I've done all the trainings, I've done the IFM, the AFORM, which are fantastic, but where I feel like I've kind of changed it up a little bit is I want the practitioners to be able to take what they've learned and apply it Monday morning into clinical. And so we always say it's from classroom to clinic. So included in their module is they get a free 4-hour shadow with me in my office. And so if they did peptides, I will make sure that we get to see peptides, or if they did hormones, I'll try to make sure we get a Dutch that day or a gut. And so there are 6 modules. You can buy them a la carte. You can buy the whole bundle. In that, we offer a membership as well, and that's $99 a month. And so that's where I was saying where my students will send me things. And so it's an ongoing, every month we do a mentor call. We have a close Facebook group where we can kind of staff cases and share ideas and all these kinds of things. So it is great. It kind of takes like a big kind of virtual thing and we make it a lot more in person. And not only that, we go over some of the business stuff, like how do you price this? How do you package it? Like one thing we do in our practice is we price all the follow-ups included in our GI map price, because I want them to stay consistent and I want them to stay engaged in the program. And so if it's already included, they're more likely versus having to like nickel and dime them every time they come in. And so we talk about those things. How do we make it more palatable on the business side, not only on the clinical side? So YDH Academy, it's all the information is on there. I also have a pretty active Instagram page, which is at udirecthealth_aesthetics. And we put tons of information there. I've got a podcast called The Better You Project, optimizing health, hormones, and aesthetics. So lots of ways.
Great. Yeah, you're doing awesome work. Thank you so much. Well, you guys know how to get in touch with us at Diagnostic Solutions. Visit our website. We're also, on Instagram. Like I said, if you haven't checked out our DSL Academy, please do so. And Jaclyn, any closing words on your ends? And I can't thank you guys enough. It's been so fun to collaborate on this. Thank you both for your time and your insight.
Yeah, this has been really great. And likewise, if you have questions about Dutch testing, it's just dutchtest.com. You can click become a provider, and that unlocks tons of resources for you to learn more.
All right. Awesome. Sounds good.
All right. Well, have a great one. Happy fall.